This meeting is now being recorded.
Okay, well, thank you, Sue. It is great to have the opportunity, and it is really an honor to spend the lunch hour with your group here from Mi-CCSI, and I really do appreciate you giving up some of your time to hear about post-acute eligibility determination for rehabilitation services. It is an area that we always get a lot of questions about because the rules change year after year, so we tend to follow this moving target. Again, my name is Tom Strands, and so I will keep an eye out for any questions that get texted in. Otherwise, I think we'll open it up for verbal questions at the end. And so we'll just get started. So in terms of disclosures, I really don't have any conflicts of interest to report for the presentation, and don't have a financial or commercial interest in any of what's being presented. I work for Mary Free Bed, which is a nonprofit 503c organization. And so with that said, we'll move ahead to the learning objectives, and there are three main things. The first one is probably the easiest one because it's really more of a list. So just kind of looking at what are the post-acute levels of care in the community for rehabilitation. And so we'll go through that just very quickly. The second one is which criteria are used to determine patient eligibility for each level of care. That one is where it gets a little bit more tricky, and we'll spend probably a good amount of time on that. And then the third one is really the value and importance of care coordination, the services that many of you provide and care management during this process. So those are today's learning objectives. So to get started here, we're going to look at defining the post-acute levels of care for rehabilitation, and this is pretty much it. So one service level is the LTAC, the Long-Term Acute Care Hospital. Sometimes you see it shortened as LTAC. And basically, as many of you are already familiar, that is a continued stay in an acute care hospital, a long-term acute care hospital, and that is, we'll go into what that definition is a little bit more in a minute, but that is the one level of care that is really still very acute. And then the other four levels are what we generally refer to as post-acute care, and they include acute rehabilitation, and sometimes you'll hear people in the industry call it an IRF, an inpatient rehab facility. That's what the Center for Medicare and Medicaid Services, CMS, refers to all inpatient rehab facilities. Sometimes you'll hear them called an IRH, which is an inpatient rehab hospital, or an IRU, an inpatient rehab unit. They're all kind of the same meaning for the level of intensity for an inpatient rehab facility. And we'll go into that detail also. There is subacute rehabilitation, which is provided in a skilled nursing facility level of care. There is home and community placement that is provided either through a certified home health agency, which means they have a Medicare certification, through a private duty service, or an outpatient, a traditional outpatient. And that one I probably won't spend much time on. I think everybody has a pretty good idea of what an outpatient rehab center is, but we'll get to that one too. And then the other one is a long-term care facility, which is more of a residential long-term setting. So those are the levels of care that we're going to look at. And then now we're going to look at the eligibility requirements to get into those facilities and to receive care. So the LTAC, and actually I looked at this earlier and realized there were changes last year that were made to the LTAC that I'll refer to that are not on this slide, but we'll make note of them. So this is really the highest level of care after acute care, and it's really for treating patients who have one or more serious medical conditions, who may improve with time and care and then go home. They're no longer appropriate for continued stay in a traditional acute care, short-term hospital. And so the medical necessity criteria are that the patient cannot safely have their needs met in a less restrictive setting like an IRF or a skilled nursing facility. So generally, if a person could qualify to be in an inpatient rehab facility or a SNF level of care, that's where they would go. So that's generally why we're backing up and looking at what's between the acute care hospital they're already in and they can't get into a SNF or inpatient rehab hospital. So the things that have changed that are really important to know now, and Medicare writes the regulations for the LTAC, and one that has changed is for Medicare patients, they have to spend at least 3 days in an ICU prior to being transferred into an LTAC. Or they have to be on a vent for at least 96 hours. So those are pretty strict, really limiting new regulations that limit the number of people or the types of patients who are able to get into or access an LTAC, who are Medicare patients. So the expected length of stay in an LTAC is generally about 25 days, I would say. They generally require these patients complex management in areas like prolonged IV therapies. Frequently, they have conditions such as ventilator management, cardiac monitoring, complex wound care. They might be on an IV drip for antibiotics. And so they're really pretty complex patients who are needing an extended acute care stay. They often are not candidates who can do very intensive rehab. So it's an important service that's provided. The rehab services that are provided are usually pretty limited levels of OT, PT, and speech. And so that is the LTAC level of care. The inpatient rehab or IRF facility, which examples of an IRF, Mary Free Bed is an inpatient rehab hospital. So it's an entire hospital designed to serve inpatient rehab patients. Spectrum has an inpatient rehab unit, so it is a designated number of beds in a hospital, a unit that is designated for inpatient rehab. And there are other similar programs in Michigan, typically units that are designated to provide this level of care. And again, the regulations defining how the service should be provided is by the Centers for Medicare and Medicaid Services. And that is primarily for services that are provided to Medicare and Medicaid patients. There are 6 things that we focus on pretty carefully, and I'll just go through them pretty quickly and then one at a time. So there has to be up front when we evaluate the patient, there has to be an appropriate inpatient rehab facility diagnosis. And I'll explain what that means in a minute, but not every diagnosis is eligible to come into an inpatient rehab facility, according to CMS. The other thing is the patient has to demonstrate the need, has to show medical necessity to be here. There has to be what CMS calls relatively intense therapy needs for occupational therapy, physical therapy, and if it's needed, speech therapy. There should be a interdisciplinary team approach between therapy and nursing, and there should be a significant amount of practical improvement expected. In other words, the patient should functionally be able to perform daily tasks better in some way as a result of participating in inpatient rehab. And the last thing is there needs to be a discharge plan that is community-based. So people are really not supposed to come into an inpatient rehab facility if the goal is to go into another institution like a hospital or a skilled nursing facility. If that's the planned result, inpatient rehab is really not appropriate. If the plan is to go live at home, then it can be appropriate, and then what's required is to look at the discharge plan and determine if there are reasonable supports that are safe. So I just had a little bit of a glitch there, and our PowerPoint system, our connection just disconnected. So I am going to log right back in. Apologize for that. So I have a standby laptop in just in case something like that happened. And so we're going to talk a little bit about the first element, the appropriate birth diagnosis. And so I'm not able to advance the slides. I apologize. So
I've just advanced it, Tom.
Okay, so I'm on number 13, Sue. And so when we talk about appropriate birth diagnosis, CMS, or Medicare, is very specific about what those are. And so you can get an idea here. This list, there are 7, and I'll show you a few more. The stroke, spinal cord, congenital deformity, amputation, major multiple trauma, hip fracture, brain injury. Those are all diagnoses that are pretty common that we would see in an inpatient rehab setting because they often involve, a pretty catastrophic situation for the patient. And so I'm going to go to the next slide. You can see neuro disorders, burns. When we say burns, usually there's substantial, significant burns over a large portion of the person's body. Number 10, now there's some interesting things in here. Number 10, 11, 12, those are all different types of arthritis. And even though those are included in the Federal Register, and they really are not eligible to come into inpatient rehab under most circumstances. And that is because over time, CMS has determined that those patients, they believe, actually do better going to either home right away, that they tend not to need to be in a hospital setting, and if they can't go home, then to a subacute setting in a skilled nursing facility. So even though they are still included and listed in the Federal Register, if we were to admit them in an inpatient rehab setting, it's not reimbursed. And so why they still continue to list those, I don't know, but they do. So even though they're on here, they are not really eligible for inpatient 99% of the time. And then number 13, hip and knee and hip replacement. Knees no longer accepted since I would say about 2007, 2008. CMS does not allow them to come in unless there are other conditions that are unexpected along with the knee replacement. So a pretty straightforward elective knee replacement usually always goes home, and if not, then to skilled nursing. So even though it's listed here, as one of the CMS, really not eligible to come in. Unless it's bilateral. If they're bilateral, CMS does pay for that. So hip replacements are never eligible to come into inpatient rehab. So just sometimes the way what the rules say and what really happens, what's really allowed, are a little bit different. So we'll talk a little bit about medical necessity. So the services, the language in the federal regulations basically say that services must be reasonable and necessary. So it sounds a little bit like the auto language. That's what auto insurance companies say. And they also say in terms of efficacy, duration, frequency, and amount. So in other words, if we had a patient who would benefit, we think for one day from inpatient rehab, that probably wouldn't be worth all of the evaluation and bother to the patient, so that would be a no. So they're really, we're kind of looking at what is reasonable. Super short stays, like a day or two, are not. But 4 days plus, 4 to 5 days is probably the shortest length of stay for inpatient rehab. And then another thing is, so that's duration. Amount of therapy, we provide a lot in inpatient, so they would expect to see the patient getting at least 3 hours a day, at least 5 out of 7 days, to show medical necessity. And another way that we look at medical necessity is to look at the presence of other medical conditions that we need to manage in the hospital versus maybe a skilled nursing facility or at home. And typical ones that we manage are diabetes that is uncontrolled, hypertension that's uncontrolled, morbid obesity, dysphagia that's new. So those are things that often make the patient more complex and benefit from an inpatient rehab facility stay. So relatively intense therapy, and so when they say relatively, that just means relative to other levels of care. And so according to CMS, if a patient needs relatively intense rehab, that would mean requiring interdisciplinary approaches to upgrade their function. And so by intense, we mean at least 3 hours a day, at least 5 out of 7 days. And when you say that to some patients, they think it's a lot because it sounds like it's all at one time. It's really not. 3 hours spread out over a day is not nearly as intense as it sounds because it includes mobility, it includes gait training, it includes ADLs, it includes bed mobility, dressing, transfers, toileting, everything that OT, PT, and speech do. So it really is not quite as rigorous as it might sound, but even at that, there are certainly patients who are not up to that amount of therapy. And again, it only includes OT, PT, and speech. And some patients who are getting orthotics and prosthetics, it includes the time spent with that group as well. Just restating the 3 out of 5 every 7 days. So beginning with the day of admission is when we start counting. Traditional Medicare doesn't require any pre-certification, so if people have traditional Medicare, we really just have to understand the federal regulations very well. I think I say they only require that we follow the IRF rules. So the IRF rules are a little bit complicated, actually, and so it can take a while, sometimes longer, to determine if all of the criteria are met. We try to do it, most providers out there, as really efficiently and quickly as we can, and but try to be thorough and make sure we've done that correctly. But we do have to follow all of those regulations that are out there, and so there is one exception there that CMS has developed. So that sometimes there's this patient who we know they really can't consistently 5 days do that 3 hours, but they're such a good inpatient rehab candidate in every way that there is the ability to make an exception and say, okay, we have a patient that we're going to document due to the fact that the patient has a history of MS and fatigues easily, for example, that we're going to do 15 hours of therapy over 7 days. And we can track it that way, or 900 minutes over 7 days. And so there are some cases where there are patients who may not be able to do the 3 hours, and we can still work around that. Dialysis is a more common one where we have people who are getting dialyzed, 3 days a week, and so we know on those days they're kind of tired. So we'll say right up front, you know what, we're going to document that and then just say we're going to do 15 hours over 7 days. And that's certainly okay to do. So that's been more acceptable the last probably 4 or 5 years by Medicare. We have to use an interdisciplinary team approach. So interdisciplinary team approach, this really is watching and being able to see in documentation and see in practice that nursing practice and therapy are working together. And one way that you might see that is during team conference. Another way you would see that is in AM and PM routines that nursing and therapy those services are being integrated to best serve the patient, and that shows up in documentation. So that expectation of working like a team and working from a common plan of care is expected. And a difference would be working as a multidisciplinary team is appropriate in acute care. It's often and certainly done in SNF level of care and a subacute rehab, and a lot of subacute rehabs do that, where you work more as an individual therapist without the requirement of being interdisciplinary. Although I will say there are some very good skilled nursing subacute facilities in West Michigan that also use the interdisciplinary model where they work as a team. The difference being that in an IRF, it is required, so you will always see that in an inpatient rehab facility. So I mentioned the team conference. Team conferences are required for Medicare patients, certainly, every week, and generally done for most patients every week. There could be some exceptions. Sometimes we have patients who have very catastrophic situations, and they might, on occasion, go every 2 weeks, but almost every patient is weekly. Significant practical improvement. So ways that we would try to identify whether there is significant practical improvement would be to look at the functional changes that the patient is going to have, or we believe the patient's going to have at the very beginning, and then we write functional goals with the patient. We have the patient write some of their own. We help them write some. The therapists write some. The nurses write some. And some of those functional goals involve using the FIM, which is a functional assessment tool that we use. It's very common in inpatient rehab, where we look at 18 different functional areas that range from transfers and wheelchair mobility, walking, bowel and bladder, dressing, bathing, and really we rate them on a 1 to 7 scale, 7 being completely independent and 1 being completely dependent. And patients are rated within the first 3 days they come in, and then weekly thereafter, and then during the last 24 hours prior to discharge. And then so we really track the changes that are occurring over time. and in subcategories of those functional categories within that tool. We also look for changes in where the patient's going to be discharged to, sometimes where we think that's going to be at the very onset of transfer to inpatient rehab. Sometimes the resources change, sometimes the supports change or discover that they may not be able to do what they thought they could do, and so those are also considerations that are consistently reevaluated during inpatient stays. And then the discharge plan. So like I said earlier, the types of discharges for patients coming to an inpatient rehab facility are people going, all of our patients should be assumed to be going to a community setting that would include a home or an assisted living or transitional living sometimes. So all community-based settings. And they need to include whatever level of reasonable supports that may be needed at the time of discharge. And that might be for a stroke patient, it might be having somebody 8, 16, or 24 hours a day to monitor or to provide actual one-to-one supervision, depending on what the safety needs are for the patient. There are times when even our best efforts and the patient's best efforts and family and support do not result in the patient being able to have a community discharge. And in those cases, we try to use all of the resources we can and use an alternate discharge setting that is not in the considered a community setting. So in most cases, we try to transfer those patients to a skilled nursing facility, a subacute rehab, so they can continue their rehab for a longer period of time and hopefully eventually achieve a community discharge. And we always try to work with the patient on that as a success. That's not a failure. There are some cases where we, at the beginning, you just can't do 100% crystal ball prediction about, somebody who has just had a severe, very dense stroke and 100% of the time predict the level of recovery back to home. And so in some of these cases, we look at all the indicators. The physician is the final decision at admission for all of these. And based on the best information that there is, those decisions are made, including the family. And when it doesn't happen, we try to make that as hopeful and supportive as we can, that there is more. And the more sometimes is more rehab that is continued at a subacute. And in many of those instances, patients do go home from there. They just really need more time. So the subacute or skilled nursing facility-based level of care is really many excellent rehab candidates who go to those programs don't fit into like the eligibility window of inpatient rehab that we just talked about. So what happens is there are a lot of people who would go to a subacute level of care who are functioning at a lower level. They're not quite able to tolerate the 3 hours a day of therapy, for example. So then in that case, they would benefit from going to a subacute because the subacute program is allowed to provide less than 3 hours of therapy. So that is a beautiful fit in the continuum that they're allowed to do that. The other thing is when I talk about the window of eligibility for an inpatient rehab, there can be patients who are walking, 150 steps after a stroke, and verbalizing, communicating quite effectively, and really don't meet the inpatient criteria for inpatient rehab facility, but they're not able to go home and live alone yet. And so they are too high functioning to get in the inpatient rehab facility, but they still meet criteria to go to subacute. So subacute kind of really has broader admission criteria and can serve people on both ends of the spectrum, either lower functioning than the inpatient rehab facility or higher functioning. And so that's how I like to look at it. And the criteria, I guess I would say on the bottom there, are not as tightly defined as the IRF level of care. So there are, I think it just kind of spells it out pretty carefully. The reimbursement is done a little differently. I would say one of the things is patients can have, 1 hour a day of therapy, 2 hours a day, up to 3 hours a day of therapy. So it really kind of broadens out who is eligible to participate. So patients in subacute, the benefit covers up to 100 days. Sometimes people hear that and they think they should have 100 days, and most people would not ever need that many. Many people go home in, 20 to 30 days or sooner, and get excellent results. They receive daily skilled nursing services, skilled OT, PT, and or speech if that's needed, or some combination of those three. They get medical social work services. Included in their service are drugs and biologicals, appliances, and orthotics. They, in order to be eligible, must have a 3-day inpatient acute hospital stay in order to be eligible for admission. And Part A, Medicare does not cover custodial or long-term services, just the short-term subacute rehab. The way that Medicare defines skilled care is requiring the skills of qualified technical or professional health level personnel such as RNs, LPNs, PTOT speech, provided directly or under the supervision of these personnel. And inherent complexity of the service such that it can be only performed by skilled personnel. So it really has to, the services are provided by skilled staff. Home health services, Medicare certified home health care services have to be referred by a physician who has done a face-to-face encounter with the patient to determine that the patient will benefit and require home health care-based services. And the reason that a person would benefit or require home health services would be because they are unable to safely leave home independently due to medical condition. They have been able to leave home with minimal effort, but there has been a change. So they may be often at discharge from acute care or from acute rehab, inpatient rehab. We have patients who certainly have gone through changes, and we recommend home care, and then they need to have that face-to-face review with the physician defining what has changed. And some examples of what that medical condition could be that they have gait instability or muscle weakness, which is a common one, when they leave rehab, inpatient rehab. It can be pain with activity, which is another common one. It can be shortness of breath, which is not uncommon after a stroke, or a deconditioned patient who you may see through your office. Cognitive deficits, another common one, or medical contraindications for leaving the home. So that's just a pretty typical list of the reasons that we would see somebody receiving home health care services through a certified home health agency. Outpatient rehab is the other option, and outpatient rehab is pretty much self-explanatory. People who are able to get out in the community, which is for people leaving married-free bed, it's about 40% of the people who leave the inpatient here, and that's probably typical for any inpatient rehab type unit or hospital, are able to go to outpatient, and that would be any outpatient therapy center, and they're certainly all over West Michigan here, where you would go get OT, PT, speech, all of them, one of them, whatever is needed. And so there's quite a range of those that require the patient to be able to get in a car and go there, or on a bus or whatever transportation they have. As far as care coordination, this is really critical because the big thing is these are tough decisions. We would love to say they're complicated and they don't change, but they're not complicated. They are complicated more than we'd like them to be because they're regulated. So we really rely heavily on what the physicians know, what hospital-based care managers know, what care and case managers know in medical homes and physician offices to help educate the family and the patient when it comes to decision making. And that would be pre-surgical, that's during an unplanned acute care stay, that could be at discharge, after discharge home. Often, we'll get a call out of the blue. Somebody was discharged, with pretty good plans from acute care, but just didn't have a very good recovery and elected not to accept rehab services and does need them now. And so there's just quite a big mixture of patient needs. And so understanding what some of these resources are by people who are close to the patient or who the patient may contact is just really, really important. And so, and understanding the big picture, and part of it is because it is complex, knowing who to contact. So there are certainly any of the agencies in town who provide inpatient rehab, who provide home health care, who provide outpatient, generally understand at least their own levels of admission criteria, if not some of the others. And we really try to get in touch with as many case managers, care managers we can. Great that you guys are embedded right in physicians' offices, because that's really where the patients are for sure going to contact. The other thing I think about care managers is just being aware of some of the standards, what's expected, what you would expect from a high level or a high quality rehabilitation provider. For example, if you're looking at a subacute, some of the things that when people ask, what should I be looking for in a subacute, or sometimes they say which one, and I'd rather say here's some qualities to look for than to choose. We don't choose for them, but we might say here's some things to look for. One would be, do they have therapy or do they have medical staff in the building? How often? Is it once a month? Is it once a week? Is it a couple times a week? Is it 5 days a week? And so, how often is the person going to be able to access a physician or a PA? Because that may be really important depending on what their needs are. Are there spaces that are really dedicated to provide rehab? Are there rehab gyms, treatment spaces? Is the program accredited for rehab by the Commission on Accreditation of Rehab Facilities? What is the average length of stay? Is there a comprehensive team approach, or is it more of an individual therapist approach? What days are therapies available? How many days are therapies available? What types of functional measures are used? And those are just some ideas for questions that I think that are helpful to empower patients and families. I think the other way to think about it is, you can have a stroke patient who might just be very borderline and may do good, and you have to look at the whole big picture of whether they're going to do best in a inpatient rehab setting or if they're going to really do better in a subacute setting. And I worked with a doctor who used to always say, I guess it's up to you. Are you more about in a situation where you're looking to sprint, or you're looking for a marathon? And usually when you interview the patient or you've listened to what they have to say, you can kind of tell that along with their recovery so far. If they're really a sprint patient who's really looking at, doing intensive rehab, having probably a little bit shorter length of stay and getting home. And if they're going to be able to tolerate that, and that's really their mindset. Or sometimes somebody who seems a little averse to that and they really just want to spend more time focusing on recovery, rest, and if they're really afraid of intensive rehab, then maybe they're more of a marathon person. So these are just some quick primers. Acute rehab, I would say that a medical necessity for inpatient level of care is important, and we have to establish that ability to tolerate intensive rehab of 3 hours a day, or at least 15 hours in a week, steady rate of progress, and clear plan to discharge to community. Subacute differs a little bit, or you need to demonstrate a need for skilled care at the SNP level of care. Therapy can be lower intensity, less than the 3 hours for sure, can have a variable rate of progress, and the discharge goal for the patient can sometimes be community reentry. They can sometimes be rehab with a plan to stay in a longer-term care setting, or sometimes, get started and see how it goes. So it can be a little looser, a little more open-ended. I'm just going to go through one example here, and this is an 81-year-old woman who underwent a hip replacement. She's easily fatigued, and her tolerance for therapy is variable. Her husband is at home, but unable to assist her physically. So sounds like she's, as far as we know, she's intact. We don't really know cognitively, but she's had a hip replacement. She's in acute care. She's easily fatigued. Her tolerance is variable. Husband is at home but cannot assist her, and she probably will need assistance. So, on this one, I would say without knowing any more than that, if she has to be in a facility and she can't be home, probably not going to qualify for acute rehab because it's a hip replacement, and those just don't get approved or covered by Medicare. She may also, because she has easily fatigued and variable tolerance, I would say she may need to go the marathon route for the subacute skilled nursing facility. So with that, I will stop talking so much and open it up for some questions.
Right, we are unmuting the line, so you'll be able to ask your questions directly verbally. But in the interim, if you'd want to put a question in the public chat area, we can address questions there as well. Tom, I did, while folks are thinking about their questions, had a question in the inpatient rehab facility and the care conferences. If we have care managers that are in the community, would they have ability to, attend one of the care conferences, especially if they were thinking about the discharge planning? Or if they weren't able to attend, who could they communicate to find out what the discharge plan is?
Yeah, that's a really good question. I think the answer to that varies a little bit by organization, by program, by provider. I can say for the organizations, including the current one that I've worked for, they have almost, and the majority of them out there, do encourage external case managers to attend team conferences And that's really the opportunity for the physician, the attending physician and the therapist and nursing to share what's going on and to also sometimes learn a little bit about what's happening, what questions there are out in the community, if it's the case manager or if it's on behalf of the family. But in most cases, yes, that's totally actually appreciated if that can happen. And the best contact is usually the social worker or the hospital care manager who is looking after that patient.
Thank you. Others, questions? Quiet group. As we move into new payment models, so today we have a fee for service, we do something, we get paid for something. We're moving into payment models where we have either shared savings or based on savings will be eligible for additional dollars. So many of our organizations are in the CPC Plus or in shared savings. And the focus of the care managers in the practice has been more on preventive and chronic care management. I guarantee you, as we get into some of these new models, there will be increased focus on managing the rehab facilities and discharge planning as well. It's just, as care managers, we need to kind of hone our skills and knowledge around this, and we will be becoming more involved in discharge planning, in ensuring safe discharge plans as well. So, thinking about, one, is this the right level of care for the right cost? So we got to think about right place, right cost, right time. And then as we think about a discharge plan, ensuring as we're discharging out of these facilities, we have a good plan in place so they're not ending up with a readmission. And I don't know, Tom, if you can speak to, the readmission and how a care manager would really think about a good, safe discharge plan from either a SNF or a rehab, and how they could be involved with that.
Yeah, I think there are a few things. One is, it's kind of funny because we call what we do post-acute, and in some ways it should be actually pre-acute because everything is sort of defined assuming that every event begins with an acute care hospital stay, and sometimes if we're doing, really good advanced illness management for chronic patients, we're catching it before it ends up in acute care. And so I think, just as a whole medical community, we're learning more about how to do that, and it may change our language. But when it comes to discharge planning, there's a few things that I think that are really important. I think one is, as somebody who's been somewhere either inpatient in subacute or inpatient in an inpatient rehab facility or hospital, that there needs to be within a 7 to 10 days. I tend to encourage that organizations do set up the PCP appointment, that's done on our end, that we make sure that happens, because the primary care office doesn't always know exactly, what's that day that they're leaving.
Yes.
And so one thing that I think that should be expected is, and that isn't always happening, and even the organization I work for is not always perfect at this, is to make sure that we're setting up that appointment when people leave here, and that our nurse discharge instructions include that appointment is set up, and we've done everything we can to get that patient, to their primary care within 7 to 10 days. I think the other thing is they often have specialist surgeon follow-up appointments, that we put that in the discharge instructions and reiterate with them what those are expected to be. so that if they have, one document kind of telling them in simple language and that's reviewed by their discharge nurse, these are some next steps for you. Here's the date, here's the time, here's the place. I think on top of that we have whatever follow-up therapies that we are going to have, if it's home outpatient therapy, if it's home health care service that's going to be provided at home, that is set up, and that if it's home health, that first appointment should happen within 24 to 48 hours. And if it's outpatient, we really need to get those appointments happening as quickly as possible so that there isn't some gap where the person's just kind of lost. I think a last thing is really where I see a lot of things break down, or we have seen a lot of things break down, is any discharge is really, the place where things can fall apart, and that is with medication. It seems like they're doing just a great discharge where people have their medications. So one thing is there a way to discharge people and hand them their medication? And so there are services out there and where you can, at discharge, hand the bag of medication and instructions to the patient versus the orders and hope they go get them. And that's just something we've discovered in our case management, director of case management, Nancy, here has spent a lot of time in working between inpatient and outpatient and said, man, the number one thing is there seems to be a med missing. There seems to have been a question about one. And she, between discharge from inpatient and initiating home care or outpatient, and that can be pretty consistent. So really switching to a model where we're handing all of the medications to people at discharge seems to be working better. So that's just an area where I think, without it being really concrete, that things fall apart.
Thank you so much. So I'm going to give folks on the line another opportunity to ask questions. And I'm wondering from any of you that are listening, any cases that you've managed that you would like to share with others and some of the lessons learned in walking through that. So I invite you to share a story or a case. All right. Well, we've got a shy group, but I thank everyone for attending today. A reminder, you will get the evaluation sent to you, and you will fill that out, and once you complete that, you'll have the availability for the continued education. We did record the webinar today, so if you have others in the organization that would benefit from the information, they can locate the Enduring webinar on our website probably in about 5 to 7 days. And with that, appreciate, Tom, you're sharing your information, helping us in the ambulatory world understand the different levels and how we can coordinate services with our facilities. It's so helpful to have everyone on the same page and working together. So thank you, and thank you all for attending. And with that, we'll be ending the webinar.
Thank you.